Hello, I'm Manoj Karmakar. Welcome to ISSPS TV. In this upcoming video, which is part of a live demonstration of Webinar 10 in the ISSPS 2021, it gives me great pleasure to welcome Dr. Adi Osman from Ipoh in Malaysia to demonstrate to us through various scenarios as to how we can use point-of-care ultrasound as part of a shock protocol in the emergency department. If you like any of our videos, do remember to like and share these videos with your friends and colleagues. If you're new to this channel, do remember to subscribe so that you can get regular notifications of any future uploads. Now enjoy the upcoming video.
I think since we probably have a lot of beginner in focus ultrasound, the first part of my demonstration, I will show how to get a view that I find very difficult.
Adi, may I just suggest we keep it simple and keep it qualitative.
All right. So the first thing is to get 90% of time, if you able the apical fourth chamber, 90% of information you can get from this view. So simply to get the view is mid-clavicular line, right? 5 intercostal space, the marker to the right, okay? And the beam is actually going to your patient right shoulder, right? So you should be able to get this. Right. So, right. If you can see carefully in this image, right, I purposely not going to tilt patient the right, okay, because in actual, in reality, this is a patient that we see. All right. So if you can see carefully, that is the LA, there's L, there is RA, there is RV. All right. So looking back at my 6 step, number 1 is look at the chronicity, cardiac chronicity. So what we're trying to determine is whether there is a sign of a chamber dilatation, right? So the few ways to do it, number 1 is look at shape. Normally the left is look like conite, right? And the right is a triangular. Any change of this shape can suggest is a possible of chamber dilatation, right? Number 1. Number 2, if you look carefully into this centimetric measurement, this is 5, 10, 15. Anything beyond 15, you can consider possibility this one of the chamber is dilated, right? And the other way, people they actually measure this diameter, I mean whether there is a chamber dilatation, right? The other thing that step 2 that we look into is other possible etiology. Looking at number 1, the leaf lag, okay, the mitral valve and the tricuspid valve, right? Sorry. Right. So the 3 that you for basic user, okay, 3 things that you need to look into when we talk about valve. Number 1 is whether there is a mass or ness. Okay. Number 2 is looking whether there's a hole. Okay. I look at carefully at the adaptation, okay, of this valve. Okay. Number 3, look at the mobility, right? The 3 things, right? So next is looking at this is apical fourth chamber. Next is we look at the parasternal marker to the right, okay, at the parasternal, this left parasternal. Okay, you should be able to see this picture, right? Just to okay, this is LA, this is LV, right? This is the LVOT. This is septum, intraventricular septum. This is the out. Right. So you're going to rotate clockwise that you get like this. Right. Remember, step 2 is looking at the functionality heart. Okay. So the most important when we talk about function is to look at the systolic function of the heart. Right. So the best way to look at it is looking at this short axis, parasternal short axis. Okay. How do you know this? This is a normal heart. Number one, if I put my marker at the center, I can see all this segment is actually contract towards, is going towards the center. So I know roughly this is probably a normal heart, number one. Number two, if you look carefully into the segment, there is contract and systole and diastole. Systole and diastole. The thickness of each of the segment, myocardium, is if the more than 30% during systole and diastole, you know this is probably a normal, right? Some people asking about EF. It's not really important because if patient is hypotensive in shock that presented regardless whether the EF, okay, what we want, the information that we want to know whether it's depressed or normal, because the next management is either fluid or inotropic or vasopressor, right? So this to look at the systolic function. The other way is to look at the other thing that I need to do is to look at the diastolic function of the heart. Right. The simplest way to do it, the simplest way to do it is to just do the apical port chamber. All right. If you see the LA, if you see the LA and LV is dilated, if you see the LA and LV is dilated, there's no way the diastolic function of heart is normal, right? So this is rough idea. Okay, some people will measure it E to E prime, etc. But it's true. I don't think we have time in managing resuscitating patient in shock. Okay, if you see the LA dilated, LV dilated, the diastolic function is compromised, right? Simple as that. Next is looking at the right systolic function. Okay, I repeat, for number 2, looking functionality, you look at left side, the systolic and the diastolic, right? For the right heart, you just look at the systolic function. Okay, why we don't look at the diastolic function of the heart? Because it's got to change and there's no management change. Okay, so this is the right side. Okay, so how to look at the systolic function of the heart is by determining how good is this motion, which is lateral part of this tricuspid annula, okay, going towards the apex. Okay, so the simplest way to do it is to patch this motion over time is to put an M mode and try to look at. So this is we call the TAPSE, TAPSE, right? The tricuspid annular cystic TAP systolic exertion, right? So of course, what is a normal number? Okay, most people will take 1.6 as normal. Okay, so you can, if less than that, probably there is some form of RV systolic dysfunction, right? Okay, going back. Right. So the next step is the most important thing is to determine. Okay, the third step is determine whether patient need fluid, doesn't need fluid. Okay, we know that 50% of patients in shock doesn't need fluid. Okay, so how to do it is 2 ways. Okay, one is to look at an IVC, okay, and the most important thing is to determine whether what you see, what you saw in this image is really IVC. Because if I tilt to the right, I can see the aorta. You see that? There's aorta, there's IVC. Right? There's IVC there. Right. So measurement of IVC must be done in dynamic. Okay. Reason why you can't do static is you get 1 point at one time. Okay. So it must be a dynamic and if you can see clearly there is a right hepatic vein. You see that? There's a right hepatic vein. So measurement of IVC must be measured before it pass through our right hepatic vein. So for example, I take this area. Okay, I just take this area. So so you can see the IVC varies during inspiration and expiration. Right? Can you see that? Okay. I personally think the best way to determine the fluid responsiveness is by doing the VTI. Look at the VTI variability. So how to do it? Try to get a 4-chamber, right? You see that? There's a chamber there. Okay. If I take my probe anteriorly, meaning anteriorly, right? So I got 4-chamber, because there's one question how to get this VTI. Yeah. So if I take it anteriorly, okay, I get the 5-chamber. See that? There's a 5-chamber. Right. Don't care so much about the structure because your focus will be on this LVO. Okay. So you see that? This LVOT. All right. So try to put the cursor at the tip of this aortic valve, PW. That's the PW. Okay. Can you see that? This is actually the VTI envelope. All right. And if I freeze it, you can see this is like the maximum velocity, right? And you can measure each maximum velocity whether there is a variation, right? You can see in this model, there's not much in terms of variability. So there's no variability, right? So I repeat how to get this. Get the 4-chamber. Okay, 4-chamber. Take it anteriorly. Okay, get the 4-chamber. Take anteriorly. It's not easy. Take it anteriorly. All right, and put the cursor at the tip. Okay. There is a variability. Okay, there's one question. I saw in the chat just now. Can you get the parasternal short axis and do a VTI? Yes, the answer is yes. Short axis similar, flex, parasternal long axis, short axis, right? But not at this level. You need to get the aortic valve level, right? Get the aortic valve level. You know there's a fold there, the aortic valve level. Just to, okay, there is RV there. Yeah, this is the pulmonary trunk, right? So what you get is RVOT similar. You get the PW there, put it there, and similar. Okay, but this is not the LVOT VTI. This is RVOT VTI. Can you get the variability in RVOT VTI in intravascular volume restriction? The answer is yes. Some people they found this having difficulty. The apical 4-chamber and 5-chamber, you can use this, right? So you can see a nice envelope there, right? And how to do basic rising test? Simple. You lift up the upper torso. Okay. Lift up the upper torso. You do the VTI. Get the VTI. Sorry. Get the VTI. No, it's not nice. Okay. Then what happened is actually, you're going to elevate the lower limb. Okay. Then you can see increase in VTI. All right. Then after that, you increase the upper limb. Okay. Similar. You can see increase in VTI velocity. Right. Okay, can you see that? Right. So next, thank you. Right. So things that are discussed by me. Okay. Number one, we look at the step one, looking at the possible pre-existing cardiac disease, right? The chronicity of the heart, possible chronicity of the heart. The etiology, basically looking at the valve, for example, in acute carditis, right? Number two, we look at the possibility of, for example, patient, whether the patient is needed the fluid or not, looking at fluid responsiveness, looking at the fluid assessment, right? And of course, the best way is, personally, this my personal view, is to do the VI and then do a basic rising test. All right. Output, some people use it to get output, but it's quite advanced. Okay. But VTI is a surrogate. Okay, because the output is always constant. So you just do VTI, you can roughly figure out the cardiac output. Right. Next is to look at afterload. This is just a subject measurement. We do the plex, parasternal long exit, short exit. All right. And looking at this short exit, try to look at the LV and diastolic area in systole and diastole, and try to differentiate, because in severe vasoplasia, in the severe generalized vasodilatation, for example, is a shock, the left ventricle and diastole during diastole will be normal, right? Both will be low in cyst, but in diastolic, in vasoplasia will be not. Okay. And last, step 6 is you can use ultrasound in a guided procedure. For example, you want to do a thoracot synthesis, you can do a pericardial synthesis. Right. I think that's about it. Any question?
Yes, thank you, Adi. There is one question from a doctor from Vietnam. I think the question is, what would be your tip in the face of COVID-19 to monitor fluid responsiveness?
One thing we found in COVID-19, the intravascular parameters to look, assess, and monitor the intravascular volume is the same to any septic shock. So your IVC variation is good, right? Your VTI is also good. Determine the fluid responsiveness. But I noticed something in COVID-19, because most of the time they are young, they are hyperventilate, increase in what I call it respiratory effort. Okay, so sometimes even those with what I call it non-fluid resp, you can see there's some changes, variability in VTI, meaning the IVC, the IVC still collapse, okay, during inspiration. So you need to be careful. I think Dr. Gabriel Via come out with 10 things that you need to be careful, determine the IVC. So my suggestion is, you want to use the IVC, determine fluid responsiveness, you need to be careful. The other thing is, in patient with trigeminal hypertension, you need to be careful, because most of the time, in patient is non-responder, the IVC is still